Thank you. Thank you very much for the opportunity to be here and have this beautiful panel to share our experiences when we are working in the resource-limited countries. We have 90 minutes to share our experiences, so my request would be that we have to stay within the time. I know you have a lot to share. So for the purpose of the audience, our panelists have a slide deck, which we will not present here, but they will be shared with you through the conference website. What we are going to do is that first we are going to introduce ourselves, maybe a couple of minutes for each of us. And then after that, I have specific questions for you based on your work and your experience. So maybe you can start from Dr. Sangeeta.
Thank you, Imran. And first of all, I would like to thank for inviting me here. And this is one of the very much gender-balanced panels, which I have been. Usually I'm very much outnumbered, but still. So thank you so much for the invitation, and my name is Sangeeta Mishra. I work as Director General in Department of Health Services in Nepal. By training, I'm an obstetrician gynecologist with a degree in public health. And right now, my work constitutes of, I look after 5 divisions and 5 centers, and one of these sections is mental health and non-communicable diseases, which I'm looking after. So this much for now. Thank you.
Hi, everyone. My name is Sander Sanoni, and it's an absolute pleasure to be here today. So I'm a research fellow at the Black Dog Institute, Sydney, Australia, an adjunct professor at Universitas Airlangga, Indonesia, and research fellow at Harvard Medical School.
Hi, everyone. Good afternoon. My name is Abdullah Al-Harun. I'm working in AID International. It's ADD, Action on Disability and Development. Basically, it's a UK-based charity organization. I'm working in Bangladesh chapter. I'm the focal of mental health and suicide prevention program. We are implementing the community-based mental health suicide activities in Bangladesh. Thank you.
Hi, my name is Lai Fong. I'm Professor of Psychiatry and Suicide Prevention in the National University of Malaysia, as well as one of the Vice Presidents of the International Association of Suicide Prevention. Glad to be here.
Good afternoon. I'm Keisha Mangalili. I am a general practitioner by practice, but for the past few years, I've been in the development sector. So as mentioned a while ago, I am the program manager for food security, nutrition, and universal healthcare for an NGO called Angat Buhay.
And finally, my name is Imran. I work as I was trained as an infectious disease epidemiologist, but recently I've been engaged with, thanks to Brian, when I met him in Nepal 2 years ago, and I was sitting there for the suicide as a preparatory project in Nepal. And as I was aware of one region, at least in Pakistan, where people were committing, young boys and girls were committing suicide. So let's try this. Let's see what is zero suicide model. So we've been implementing that, and there is a lot of learning, and there is a lot that I can see. And thank you for all of us for educating me and trying to emphasize. I think one critical piece is to bring people who are not working in the area, because everybody is here working on suicide. So we need to bring more people who are not working on suicide so that we can have a larger audience. And I'm one of those. Brian, you were successful in that. Our organization is a research-based organization. We work in public health in general. And I'm representing here today the team who are working on a zero suicide, where we have contextualized the model that was shared with us, Brian. We have put in some digital components. We also put in some art-based methodologies in it, and we will share slides with you, so please look at them. And I think what I'm realizing that, and from the panel today, is a lot of experience that we are going to share with you. Basically, the purpose of this session is to try to understand the challenges. And when the word challenge comes, I mean, I am hesitant to use this word. I think it's more important to look at the opportunities that we have. If we continue to complain about the low resources that we have, I don't think we will be able to address any of the challenges that we have. So what I would encourage our panelists is to try to talk about how we have managed within the limited resources that we have, and how we have made sure that we highlight the issue we try to come up with the solutions and then implement the solutions, and then where are the barriers that we can address. With that, I would also request that if our responses are specific, and I got some hints from Kathy that if I interrupt you, so please do not mind, because my job is to keep the time. Because everybody it's a very cross-sectoral area, suicide, and everybody has a lot to share. Definitely, we would like to stick to the time. So I'll start with the area that since morning we've been talking about is stigma. And Li Fong, my question to you is about that. What are the cultural barriers and beliefs, and how is stigma a barrier to zero suicide or suicide in our countries?
Yeah, thank you, Imran. I'd just like to bring everybody's focus to what Imran has just said, as well as what Professor Khalid has just mentioned about decriminalization. So I'd like to share a kind of case study from Malaysia. We have just decriminalized attempted suicide last year. So that's a big win. And there is no one person who was key. It took an entire village, an entire nation to do it. So I think one of the crucial things that came to crunch was there was political will. There was a change in government, and they actually saw that the stigma and the taboo against suicide was something that was really difficult. And if suicide was criminalized, it would actually hamper the efforts to suicide prevention. So the gateway and the opportunity that criminalization of suicide came was when suicide attempts was decriminalized in Malaysia. It opened doors for the SOPs to actually have the police, the first responders, the social workers, the maritime people, as well as the civil defense to come together and be together with the health services to work as a team. So what's happening now is we're going to have suicidal crisis negotiation trainings where the frontliners who have never been exposed to suicide prevention training actually are equipped to respond to a person in suicidal crisis. And this would not have happened if suicide attempt was not decriminalized in Malaysia. And so even with the parliament passing the laws, it is crucial for royal assent because we are a parliamentary monarchy. We still need the king's assent for the law to be passed in Malaysia, and as well as to be gazetted in Malaysia. So this actually opened doors for wanting surveillance to be mandated in law to be accurate. So many challenges that you saw Professor Khalid highlighted where there's very poor or underreporting, this will be actually kind of like opportunity to do it right instead of having guesstimates. And also we are very aware of the impact of suicide on the frontline responders, and postvention would be something at the core of the efforts after decriminalization of suicide attempts. And that just goes to show that people who have been exposed to suicide are at higher risk of suicide, and things need to be done to actually lower that risk in them. So I'd just like to stop there.
No, thank you. Sandy, just following up from Dr. Khalid Said's presentation, I know that you have worked on working with the religious leaders on addressing the stigma and decriminalization. Please enlighten us on that.
Sure. Thank you so much, Imran. So in 2021, we started the Indonesian National Suicide Prevention Strategy, where we began with a situation analysis. And one of the things that we discovered is that since the 1960s, Indonesia had outstanding legislation written for disability and mental health that was never carried out. And so they've been advocating for suicide prevention since the 1960s, but it never really came to fruition. And one of the things that we realized is because maybe the advocates shouldn't be the academics, it shouldn't be the doctors, but it was a country that was wholly founded on spirituality and religion. For example, it is one of the largest, in fact, the largest Islamic country in the world. And so what we did is we worked together with religious leaders because we understood it needed to be them on the platform using language that they use and understood. One of the most common questions we get in any mental health or suicide prevention sessions that we have, for example, is number one, is suicide predestined? Another one is, how can you tell the difference between somebody who's having a psychotic episode and demonic possession? And so if we were taking our approach only using the medicine, only using the statistics, it would never get to the population that we needed to. So we needed to speak in their language. So what we did is we actually studied the Bible, Quranic texts, we studied Jewish texts, we studied the Abrahamic and the Samsaric religions down to what they individually meant. And I can even provide quotes that are actually, that I won't do in interest of time, but even from the Islamic Encyclopedia of Jurisprudence, and combine that with some of the Kuwaiti Encyclopedia on how that talks about the agency of suicide. And so what we did is we worked together with the religious leaders, and we decided to have a declaration in 2022 as part of the G20 as it was being held. We call that now the Lombok Declaration. Whereas what does the theology, it's a theology-based, across all the different religions, a theologically backed statement on what it means to prevent suicide and mental health. And as a result of that, we worked together with the religious leaders to then take that declaration to government. And as of 2023, for the first time in Indonesia's history, suicide prevention is mandated in legislation.
Excellent. So, Keisha, following up with the stigma and the community's engagement and the responses, our responses towards suicide, our suicidal behaviors. Share with us some of your work that you have done working with the communities on this topic.
So my work in mental health actually started during the COVID-19 pandemic. I was with the Office of the Vice President at that time. And it was a time when we were receiving on the news that there were a lot of deaths from COVID not reaching the hospital. So initially we set out to implement or institute a platform, a telemedicine platform that was supposed to provide COVID-19 services. So that was the first part of the program. But we were receiving a lot of requests for mental health because since it was COVID at the time, almost all resources were diverted to COVID-19 response initiatives. So within what we call the Bayanihan eConsulta telemedicine platform, we provided mental health consultations for patients who came in to us. But before we started, we were wondering, like, how do we manage the volume of patients coming into us? Luckily, when we sent out a call for both medical and non-medical volunteers, thousands reached out to us to share their willingness to be of service. And at the time, we realized that a lot of people wanted to help. They just don't know what platform to use or where to approach. And I think since then, we've implemented Bayanihan eConsulta when we ended the program as a government initiative in May of 2022. We served over 50,000 patients, including mental health. And I guess it was our first venture of integrating mental health into primary care, because at the end of some of the consultations that we've had with our volunteer doctors and patients, there was always a question of, do you want to talk to someone? Since we were on lockdown for a very long time and a lot of people were living alone. So there's always that question of, oh, do you want to talk to someone? Is it okay if I refer you to our mental health arm of the program? And right now, as a non-government organization, we've continued the telemedicine platform, but we're slowly transitioning it into a more mental health focused initiative. So we've excluded our other services because in the Philippines, mental health is still one of the most inaccessible and unaffordable services to get. So mental health was only recently included in our national health insurance package, and a lot of our health management organizations, or HMOs, who cover most of our medical care services do not have mental health services included in the package option. That's why for us, we continue to provide free mental health services to our patients. However, we're looking into exploring more community-based approaches. So we've been working with Dr. Yan to train some of our volunteers on evidence-based mental health interventions. And we're also looking into collaborating with other mental health organizations in the Philippines so that we can widen our scope and include schools, workplaces, and communities in the work that we do.
Oh, excellent, thank you. Dr. Harun, so what culturally sensitive approaches can be used, any examples from your work that you are doing in Bangladesh to to minimize the stigma as well as to address some concerns.
Thank you. First of all, suicide prevention efforts are limited by high treatment gap in Bangladesh and as well as in the Southeast Asian countries. So, yeah, we have 94% treatment gap for adult and 91% for children and youth. So, considering this situation, actually we are trying to work with the collaboration with the government. So private sector organizations, including us, we are actually trying to integrate the integrate the mental health and suicide prevention activities in the primary healthcare system. So Bangladesh has a wonderful structure on primary healthcare. I mean, there's at the grassroots level, started from the grassroots level, the community clinics in every villages. So we are trying to actually train up the community health workers who actually working as volunteer with a salary also, but they have the structure, the limited structure. And in the next tier is the sub-district level, the health complexes. So we are trying to actually build the capacity among health workers on mental health and suicide prevention. And as well as we are also developing mental health first aiders, mental health and suicide first aiders in the community level. So far we have 500 mental health first aiders in the country. They are working so that they can actually at least give the support, primary support, and they can make the referral systems for the further treatment or further support. And in every year in Bangladesh, 2.6% suicide is increasing by suicide at 2.6% in every year. So far, in the last 6 years, almost 70,000 people died by suicide. And among the students, this is higher adolescent group. So we are also working with the educational institutions, both for students, the peer support activities, as well as the teacher support as a mental health first aiders. And also we have one community approach that's working in some climate and disaster prone areas, hard to reach areas and urban slum areas. So this approach is working well. And recently we have developed one agreement with the government. As you know, Bangladesh has the DG, Directorate General of Health Services, and mental health and suicide prevention is under the non-communicable disease program. So far, as a result of our advocacy, this is the good news that recently government developed a separate sector program only for mental health and suicide prevention. So previously they are working with 22 non-communicable diseases with mental health and suicide preventions. So from now, there's already passed in our parliament. There's from this month, from the next July, so mental health and suicide prevention should be the separate sector program. So we are hoping that as we have limited budget, there are only 2.6% of the total national budget for health coverage. Among them, only 0.5% for mental health and suicide prevention. So we are hoping that after developing the separate sector program for mental health suicide prevention, that budget also will be increased. Yeah, thank you.
So that I'll come to Sandy. We talked about surveillance. And then Li Fong, you mentioned underreporting. So maybe Sandy, start from data. How can we collect surveillance? And then how do we package it for people to understand it?
Yeah, that's a really great question. And I just want to mirror something that Professor Khalid said in the previous session, where in a lot of settings, surveillance is a very real issue. Sometimes it comes down to the data pipeline. Sometimes it comes down to the methods and protocols used by people who are told to investigate whether suicide has occurred. But one of the things that I've observed across many different countries and settings is that it's very rare that we can strengthen the surveillance of suicide for a specific setting without going to the anthropological and ethnological experiences, especially when it comes to stigma. So as when we talked about before, when you're in a country where suicide is either criminalized or in fact suicide is considered a cardinal sin, it becomes very difficult when that stigma is incredibly pervasive. And so as a result, we saw from the previous presentation that a lot of countries just don't present their suicide numbers. We know that whether it's from the WHO Global Health Observatory estimates, whether it's from the Global Burden of Disease, a lot of the times we just rely on projections and estimates. And so I just want to, I'll quickly close off this point, but I want to circle back to the idea that we have to understand what are those people experiencing when they have to write down that it's a suicide, and what can we do to tackle it? So for example, from a religious perspective, if I go into a setting where suicide is a cardinal sin and I try to dissociate suicide from sin, what they hear is that I am rejecting their identity. So rather than going there and saying that suicide is a sin, the approach that we would then take is, if suicide is sin, then how wonderful is it for us to prevent it? That if suicide is a sin,
Yeah.
then how incredibly noble is it for those to seek help so that they may not sin? And how horrible is it that you would discriminate against someone, increase their risk, and cause them to commit that very sin that you so abhor?
Excellent. I think that brings us to the communication part, and what Dr. Mishra also mentioned, that it's not about what information do we have, how do we package it. Le Phong, about underreporting. I know you have something to talk about it.
Yeah, actually, it's not just about underreporting. I would like to actually, if you don't mind, shift the focus a little bit about the perception that LMICs are always under-resourced and we are always at the learner's end, and we always have to learn from high-income countries. I think that the Lancet Commission on Self-Harm is going to come out soon, and perspective, one of the pillars, the LMIC pillars, is that there are many things that the high-income countries can learn from LMICs, and I'll give you some examples. In terms of policies and legislation, pesticide bans have been proven to actually decrease suicide death by pesticides and all cause of suicides very much in Sri Lanka, in India, as well as in China. So I think that there is a very big story to learn from that in means restriction. So for example, in the US, guns are the #1 cause of death for suicides. So there is a huge story to learn about how to restrict access to guns in terms of legislature. Of course, we can talk about lock boxes and safe keeping of guns, as well as pesticides. But if we were to look at the pesticide story, the RCTs in Sri Lanka showed that if you locked pesticides, it did nothing in reducing suicides. You actually have to have a big policy implemented to actually just ban hazardous pesticides. So there's one story to learn from. So another story to learn from is cash transfers that have been done in Brazil, a lower middle income countries, where they actually do cash transfers to families who are actually in the underserved and marginalized populations, and it actually showed that suicide rates actually reduce. So there's a huge story to learn even in high-income countries where there's a disparity between the high-income earners and the low-income earners. If you could just imagine doing cash transfers, you would actually look at the social determinants of suicide beyond the healthcare models, poverty, education, education attainment, and so on and so forth. So I think that we need to have a paradigm shift in the fact that the LMICs always have to just learn, but we have a lot to give as well.
Definitely, I think you and I need to talk more. I'm very convinced about that as well. And I think John and his team came up with the term reverse innovation that we always talk about. There is a lot that we can give, and that's also very important for us to share our experiences, something that we are doing right now. Keisha, what do you think are the gaps in mental health infrastructure and how those can be addressed?
For us in the Philippines, the way our health system is structured is that it's devolved ever since the 1990s. So the burden or the mandate of delivering health services is actually placed on our local government units. And because of that, even financing is managed by them. It's highly politicized in the Philippines. So if health is not a priority of the current administration, means you won't get anything. Like you won't get any resources, you won't get whatever it is that you need to get to deliver these basic healthcare initiatives. For us, I think this, well, not the good thing, but the implication of this is that people don't know where to access these services, or sometimes if they do know where to access services, because people aren't earning enough, like our daily minimum wage in the Philippines is around $10 per day. And the cost of going in for a mental health consultation would be around $17 for an hour session without your medication. And the burden, the financial burden is placed on our patients, like around 50% is out of pocket for all healthcare expenses for us, so that prevents them from actually accessing the healthcare services. Recently, the Universal Healthcare Law was signed, and it was supposed to be implemented in 2020, but then COVID happened, so everything was restructured and reorganized to go to COVID services. But right now, as part of the new administration's national 8-point agenda for healthcare for this current term from 2023 to 2028, mental health is there. And along with the discussion of strengthening our primary care services, there's also the discussion of integrating mental health services, which is why we also included mental health in our national health insurance packages. HMOs are now beginning to cover or are now beginning to provide mental health services for our patients, not just for curative purposes, but also for preventive purposes. We have well-being programs being introduced in workplaces in the country, but these are still focused on either tertiary facilities or with the private sector. So hopefully with this new 8-point agenda of our local health ministry, we really do, because it's actually included there that we have to do a whole of society approach. So they've talked about including the different sectors in the strengthening of our mental health initiatives. So we have talking or training our teachers, our guidance counselors on how to detect students who are having mental health concerns. We also have improving the wellness or well-being of workers in workplaces. But yeah, the disconnect seems to be from like the policy and then the actual rollout or implementation of things.
Excellent. Harun, how can national and international organizations collaborate with the government for resources? This could be financial or human resources. How can we support that component?
Yeah, I think that we have some international organizations, I mean the donor organizations, they are giving the financial support to the NGOs for implementing. But I do not believe that's the one 3 or 4 years project can reduce suicide and improve the mental health support system. As is a bigger aspect and the main responsibility on the government. So government is the main initiator to implement activities to prevent suicide and improvement of the mental health. But for advocacy level, I can say there's just happened in Bangladesh. There's NGOs are working tremendously to advocate with the government for policy development, policy formulation, and policy implication. But we have tremendous policies in our country. We have Mental Health Act, we have a Mental Health Strategic Plan, and suicide prevention strategies inbuilt in the Mental Health Strategic Plan. But I think the gap is in the implementation. So private organizations, NGOs, and some organizations are implementing the projects, but that's playing some role to prevent suicide in the community level, but not vastly. So I think that we can increase the funds. If we have a collaboration with the government and non-government organizations, we are always, the non-government organizations are willing to support the government for collaborative activities. But there's a limited resources also in the NGOs. But I think that as WHO is supporting in our countries and some other LMIC countries also, so they can actually increase the funds. And I would like to mentioned is that we need to increase the budget, the national budget, for mental health and suicide prevention. And what I have said earlier, that we have limited resources, not only the financial resources, but also the human resources. So like Bangladesh, we have only 350 psychiatrists for 175 million population. So
That's
this
a
is
lot.
huge gap. And we have only 565 clinical psychologists for the same population. Only with 700 mental health nurses for giving the support. So you can imagine how we can improve this with the financial resources from the private sector. But I think that's we have big corporate organizations in our country. If we can utilize the CSR funds of the corporate organizations, we can increase the budget. But still, we think that we need more investment for mental health and suicide prevention, like our countries and LMICs. Thank you.
Thank you. Dr. Mishra, suicide is a public health problem, and public health is multi-sectoral. So in your position, how do we bring other sectors into, like you mentioned about these, you mentioned in your previous response, these municipality teams, like something of that sort. So what should be the government's approach towards making it more of a public health problem and multi-sectoral?
What I will say, like when we are looking at suicide, maybe like we are not looking at it very holistically. Like since morning, I was like listening to the presentation, and there were some very beautiful recommendations that have come from the studies. But they were like basically more on the clinical care part of the things, like while we are doing the clinical care, how do we decrease the suicide and what was the status of the mental health? But what I will say here, like from a policy point of view or from a public, as my own expertise as a public health, I feel that the concept of self-care needs to be brought in. I mean, until and unless that we understand that what is the meaning of self-care, and until and unless we understand that it is the meaning of family care type of model or community care type of model, we are not going to do very well with the suicide prevention. So that is one of my things. So when we talk about the multi-sectoral approach, the first thing I would say that it is the basic thing would be the community engagement. How do we engage our community? And when I talk about engaging the community, it is basically the meaningful engagement. It's basically when, most of the time we write in our papers or in our documents that we will do community engagement, but we have never actually formed community groups or how the community will be engaged. The first thing would be that. The second would be I'm talking from a totally Nepalese perspective, so it might be different from for different countries. I have never heard or I have never seen people doing audit of suicides. I have never seen those because in my country also, police takes they are the in charge of these all suicide cases, and the data is basically with them. Health sector is involved only when these people are brought in for the postmortem, because by law, each and every suicide needs to get a postmortem, so the hospitals are involved then. But nobody knows what happened in between, and even the hospital don't have any idea, like we don't get any reporting back. So maybe it would be a good idea if we could make an audit of the suicides, so that this will give you an idea that what actually happened, what were the triggering factors, what was the area, what was the means used, or where was the suicide happen. So that can be one of the area where multi-sector approaches needed. So auditing the suicide cases. The third one, which I always say, as I already mentioned, that sometimes we feel that resource is limited, but actually it is not. Which I have seen that people duplicate things. Even in my country, I have seen researches that is like duplicated. And there are, yesterday I was talking to John as well, but then there are gray areas. And these gray areas are the exact point where we can actually work on. So, I mean, researchers may be different. people may have different objectives, but still we have some areas which are very common, and those common areas, if we could cash on those common gray areas, maybe that can give us a robust policy implementation ideas or some guidance on that. So that would be the third thing. And the fourth thing, as I said, that we always talk about monitoring and evaluation. We always talk about surveillance, but how to, build a efficient surveillance system, that is very much needed. And as I already mentioned, that death audit suicide audit can be a part of that. So how do we form a functional surveillance and reporting back mechanism that is needed? So as a whole, as we always say, that it will require a whole of society and whole of community approach. So maybe we need to think very differently now, that how do we move ahead, taking into the consideration about our limited resources and knowledge.
Thank you very much. I think that those are really critical pieces of information that we need to look at it as a holistic public health problem, and there has to be beyond clinical aspect of the reasons, the factors. There are many, like social determinants, commercial determinants that need to be taken care of.
Yeah.
This is an age of technology, Sandy. I'll come to you. Everybody wants to do ChatGPT and AI. Can we do something there?
Absolutely. Oh, I feel like this session is going so quickly. I feel like I'm running out of breath because we're so pressed for time. Taking a deep breath. All right. So that's a really good question. But before that, I just want to take 30 seconds to outline something. So I've been getting a few funny looks today, and for good reasons because of what I'm wearing. So I thought I'd just take 30 seconds to explain what this is. So this is actually batik. This is traditional Indonesian wear used, and it's the method used across many Southeast Asian regions. And so what they do is they use a pen with wax. They outline each and every line, they dye it, and they repeat the process all over again. And given that we're talking about stigma and culture, I thought I'd wear this today. This was my late father-in-law's. But with the design, what it actually shows, these are actually waves breaking on rocks. And it's supposed to symbolize the ongoing consistency of both human suffering and resilience. And so this is what Batik Parang represents in my culture. And so completely unrelated to that. So talking about ChatGPT and AI, now there's two sides of that. It's specifically generative AI, as you mentioned, but also the digital approach as a whole. Now, I think that for many of us, at least for me personally, digital mental health and suicide prevention hasn't lived up to its initial promise. And the reason is, it seems like through our excitement, we've taken the lens of digital approaches through what it can provide for us as service providers. It's flexible, it might be scalable, rather than digital because that's where people are. And the reason is we've developed tens and maybe even hundreds of apps globally that aren't being used at all. Some of them evidence-based, some of them not. But we were so excited at creating something because it offered us all these different features without consideration of how do they fit in a person's day-to-day habit. So number one, I think with digital approaches, we need to really drill it down to what is a person doing in their day-to-day lives? How are they engaging with this digital technology? Which brings me to generative AI, where generative AI is being used quite widely. The uptake of generative AI has been absolutely staggering across the world. Now, I can't say much because the evidence is still very new. In fact, the evidence is still very much missing in a lot of places. There has been a few studies here and there showing that generative AI can, in some degrees, outperform a counselor if it's trained properly, according to independent raters. But no one's actually looked about ChatGPT or Gemini, how it used in its native settings without having that sort of thing. That being said, I would encourage all of us to really have a look. And the reason is there's a research coming out of evolutionary biology, which suggests that human relationships and groomings, especially for lifelong partnerships, came not necessarily through touch, but it really took off at the advent of language. That's how human beings began to groom one another and to assess whether a person could develop partnership. That's why people fall in love with these generative AI characters. But at the same time, that suggests that generative AI is, to some degree, able to generate feelings of empathy and connectedness, which is absolutely crucial in times of crisis. So this is all very much just my opinion. There's a lot of work that needs to be done, but I think there's a lot of promise as well, as long as we don't base it on what's convenient for us as the service providers, but where are they and what are they doing day to day?
Thank you. And just for everyone, I'm sure you have a lot of questions. We'll allocate some sufficient time for question answer session. So please write down your questions, and you will get a chance to ask. I know it's a lot. I'm sorry about pushing everyone to answer the questions. It feels like an exam. But I'll ask each one of you to reflect on scalability. For example, Zero Suicide model, we are learning a lot, and we have our own ideas. And we go back and we try to implement it. What are the scalability challenges that we may have, starting from you, Keisha? Quickly.
Okay. For us, what we experienced recently was that since the services that we offered was free and we were open to people nationwide, so we were covering 110 Filipinos, it was very difficult for us to keep up with the demands in terms of human resources. So our mental health professional to Filipino ratio is less than 1 per 100,000 Filipinos. So right now, we are actually trying to look for a scalable model, because right now what we're doing is still limited since we're only focusing on direct service provision, which is one-to-one consultations. So that's why we're also venturing on community-based interventions, as mentioned by my co-panelists. Really, in countries like ours, the community is a very close-knit group of people, and we need to maximize the potential of utilizing the community as a means of creating a protective environment for people, so they don't reach that urge to suicide. So. We're still looking actually for a good model for us, especially with the concerns, the logistical concerns of data connection, signal, internet. It's not very good in a lot of places in the Philippines. That's why we went analog initially with our telemedicine platform. Like we didn't require people to use video messaging. Sometimes telephone calls were enough because we were able to deliver the services. But with all these challenges, we are really leaning toward community-based interventions and involving different sectors in our approach to mental health and suicide prevention.
No, thank you. And I think you're right. Our experience in Pakistan has been the same. We screen people, school-going, high school children, and then we referred them, but then there was only one in the province that we were working, only one psychologist. There were no other support systems. So we thought that, okay, we can connect them through, do telemedicine or teleclinics for these children and people sitting in Karachi or Lahore. And the network was a challenge, so we were unable to have all of them to take all those 6 or 7 sessions. So those are some of the challenges with scaling up while we think of course, human resources is a major challenge, but otherwise, even if you have the model available, it becomes difficult to try to reach everyone. Lafang, I know.
Yeah, I think the issues are pretty similar, so I won't kind of rehash them. All these things about telehealth, they're really good, but there's a digital divide when people do not have access to internet. So we also went analog during the pandemic, where we just did telephone calls for consultations when there was lockdowns. But I'd like to just shift the ball a little bit to talk about media and its power in terms of suicide prevention. So as we are speaking, I'm missing out on, I think, a pretty important meeting with the local agencies, whereby we actually got buy-in with the media regulators, which are actually industry players who self-regulate the media. So, you know, we talk about safe messaging and preventative suicide, Papageno effect, how it can protect people from recovery stories, how it can be protective when people learn about recovery stories of from a suicidal crisis, and the Werther effect, whereby there are copycat suicides. So I think Professor Khalid just showed us that the adherence to safe reporting in a lot of low and middle income countries is not very good. But we in Malaysia have actually got buy-in with industry regulators to actually rewrite the content code that actually the media industry already has bought into adhering their self-regulation policies. So I think this is something that we can learn from, and that even using industry regulation, it can actually regulate the media well, and we can have actually preventative efforts through the media. So that's my bit.
Harun, next to you.
Thank you. I think towards zero suicide, first of all, I would like to say that we need to strengthen the community approaches. First thing, so whatever we are practicing in different countries, we can see the approaches and also more evidence-based practices we can introduce in our own areas. And second thing is that we need more empirical study. So you know that we have data gap on suicide. So as well as decriminalization of suicide is important thing. I think there are a lot of barriers due to the law. That's for example, in our country, we are following Bangladesh Penal Code, which is actually derived from the colonial rule, the Indian Penal Code 1860. So we need to change the law, and so that the people can get the support, especially who have the non-fatal suicide attempts. They have the barrier due to the law to get the support from hospitals. So they have faced actually a lot of questions from the police department for suicide ideation and non-fatal attempt to suicide. And also people are not actually willing to discuss still due to the stigma and negative stereotyping. And we need to actually more implementation process, not only the clinical aspect, we need to both medical and social model to follow for scale up our activities. Yeah, that's all. Thank you.
All right, Sandy. Scale up.
Scale up. Scaling up the zero suicide framework. So I think one of the things that we do need to recognize is that as it stands currently, the zero suicide framework is very healthcare based. Correct me if I'm wrong. And we've heard some tremendously wonderful findings this morning. A study that I ran in Indonesia found that 65% of individuals who indicated they were having suicidal thoughts haven't talked to a professional. 55% of them who indicated they were having suicidal thoughts have never talked about it to another living human being. And so because of the vastly different circumstances, we require very strong ethnological and anthropological approaches to not only understand the what, but the how. And so in order to scale up, I won't rehash some of the important things said before because in the shortness of time, but I would like to close off by saying this. As it stands in its current model, as wonderful as it is, I don't have an intention to implement zero suicide in Indonesia, but I would love to co-produce it, mirroring what we talked about by Becky this morning.
All right, thank you.
Scaling up.
Yeah,
So,
scale up.
I think for scaling up, the first thing would be like the internalization that we need to do. So I think the first thing would be political will. And how do we create this political will would be the first scaling up at the political level. Once we take care of this political will and advocacy, I think the things fall into place. The other thing would be, which we currently we are practicing in Nepal, or we are trying to integrate, is like the traditional medicine and the alternative medicine with the suicide prevention or with the mental health strategies just to promote the mental health. So that is one area where we can actually scale up not only the treatment part of it, but the self-care model, which I was talking about, the meditation and the and the alternative methods would be one of the areas. The other area which we have explored is as my previous speaker was saying, that the media guidelines were formed, and we are trying to train the media personnel. Until now, we have like around 300 media personnel have been actually trained. But what we realized that it is the training of journalists more than that was the training of the editors, because those are the people who are the gatekeepers of these news. So we are just thinking, and we have planned the training of editors, the news editors. And especially the problem right now, which Nepal and most of the countries are facing, is rapid increase in the online media. There is so many online media that you cannot actually take account of them. So how do we prevent the sensational reporting of suicide cases? And the third would be task shifting. How do we do the task shifting? Because in all the South Asian countries, we have very limited human resources. If we say in Nepal, it is just 0.5 psychiatrists per 100,000 and 72 nurses per 100,000. So the lack of human resources would be there, but how do we fill in this gap? So the task shifting models and the actually training models, how to develop the training models for each of the cadre, because mental health is not a very isolated thing. It involves all the care. It is not a different department. So how do we integrate the mental health component in each of the medical specialty, not only as a psychiatry or not only as a separate field, but how do we integrate mental health component in the academia, and how do we take that into curriculum? So that would be one area of scaling up. So I'll stop here.
Yeah. No, thank you. I think you mentioned a critical piece that not only for mental health or for suicide prevention, we have that challenge. We have a project on preterm in Pakistan, preterm births. You have all these beautiful neonatal intensive care units with no neonatologist. So we are working to try to see that, okay, what are the basic life-saving steps that you can teach a nurse, or even lower than nurse, where you can prevent life. So it's not to have people to train them, but it's basically saving life. So is that something that could be also tested for zero suicide? Do we need psychologists or psychiatrists, or can we go down to lower level and have a...
I think we can go down. I'll just share one example or my experience that in Nepal, like many people who have known Nepal or their work, we have this beautiful network of female community health volunteers. And these health volunteers were very crucial, and they played a very critical role in actually decreasing the neonatal and the maternal mortality. And when we talk about the mental health, because these volunteers, they are present in the community, and they know each and every household, they know about them. So maybe, as you said, that we can actually go little bit down, because we need here, what we need in a country like ours is the identification of the problem and then proper referral. And you don't need psychiatrists for each and every problem. Actually, we need to identify that. So the level of the care and how do we do our referrals in a very pragmatic way, I think that would work in a resource-limited country. So yes, I would agree that we can actually train our cadres according to their education level, and we can do well.
Similarly, what Dr. Khalid Saeed mentioned about faith healers, right? People do go there. So I think what critical piece that we need to do, and we are trying to do that in Pakistan, is to reach out to these people who people are accessing for whatever reason they are going to them, and let them know that, okay, this is the level where your management of this specific case is going to be dangerous. So that is where you should refer. Or just try to channel their knowledge and their information, because otherwise 85% of healthcare is not through public sector in all of South Asia. And they go to a healthcare provider. I have met people who used to be a physical training instructor and now was practicing as a doctor. He was really called a doctor. So in that environment, what needs to be done, because we cannot force them. People would not go. It's so easy for them to walk out and there is a pharmacy. And Linda has worked on that. There's a pharmacy and they go and they get the drug. So instead of forcing them to walk 30 minutes to a specialist. So those are some of the challenges that I think are really critical. Yeah, Harun, go ahead.
Yeah, that's in our practice. That's we have already religious leaders and traditional healers included as a mental health first aiders. So we included them with the training provider so that they can support instead of their traditional approach, so that they can primarily they can take care, and they can build the referral system. And second thing is that we have the helplines. So some helplines are owned by the government. There's a 999 especially for police support. So we are actually train up the police department activists on mental health and suicide prevention, so that they can also support. They have the countrywide access, so anybody can take the help 24 hours by 7 days. Yeah, so that's the important thing to scale up the helpline process, as well as the community level approaches. Thank you.
I'll just take 10 seconds. One important piece which we all are missing here is the role of private sector, because like South Asia have a very strong presence of private sector, and when we see the private hospitals, the mental health piece is totally missing. Yeah, they are psychiatrists, but then how do we find ways to involve private sector as a part of their social responsibility? I'm not talking about the private business here. So how do we engage private hospitals and the private sectors in as per their responsibility? And the similar thing which has struck in my mind is that we are thinking of having a school nurse program or the adolescent health program in public schools, but what about the private schools? Private schools are basically, they are immune. And when you look at the data, how many students are actually going to the public schools and how many students are going to the private school, the data is totally, I mean, like, it's just the opposite way. So maybe how do we engage with the private sector, whether it is the schools or the hospitals, in preventing suicide as well as in promoting mental health would be a challenge, but that would be a very great area to explore. Thank you.
Yeah, I'm all for co-creation, Sandy. I think that what I mentioned, that when I first was introduced to Zero Suicide model, and we went back, we took that model and then we tried to contextualize it, and then try to see that how this can be implemented. And that was implemented in the northern areas of Pakistan, which is going to be differently implemented in Karachi. So when we say contextualization, it has to be different even within the country. So we can never pick a model from US and apply it in Indonesia, Malaysia, Pakistan. Each country, there are 10,000 islands in Indonesia, and all of them are different, so I'm
15,000.
Oh, sorry, my data is not updated. I know you guys have a lot of questions. I just wanted to take a moment to see that if there are, please raise your hands if you have questions to see how many. Okay, so we need a lot of time. Before we go to the audience for questions, any final thoughts before you are asked by them instead of me?
Make that comment that I think this is a perfect opportunity. Thank you so much for the organizers, because we are having bi-directional learning, multi-directional learning, and I so appreciate it so much.
Yeah, thank you. Sandy, you wanted to say something? No? Okay. So I think we can take questions now, and we can start from here. From here.
Thank you. Peter Ilves from For Mental Health. Sandy, first I want to go back to a point you made about generative AI on a personal level. So I've been re-researching our training end-to-end, creating a library, and the most empathic support I've ever had was from generative AI, constantly saying, are you sure you want to be looking at this? And here's some resources that you might want to access. And it just kept reminding me, which was really interesting. But actually, I want to make a comment going back to Chen Lai, Professor Fong, that you made about Bolster Familia, the sort of financing of a very poor socioeconomic community, where there are conditions where in the Bolsa Familia you received a small but reasonable amount of money as long as your children went to school. And the outcomes of that study were so huge because they were looking at almost 100 million contacts in that study that they did. and showed very clear-cut evidence of reduction of suicide in comparative populations. It seemed so obvious, and they're going to follow it up, I believe, with the children in the future. Will their suicide rates be lower who attended school because of that? And, you know, just as a converse to that, in the UK, when we've looked at suicides associated with removal of benefits, which were some studies done about 12 or 15 years ago now, which were clear-cut, how do we take policymakers and budget holders to the point of using such irrefutable evidence to make a change and make that investment in populations? How do we do that? Big question, sorry.
I don't have the answer for that, but I think first of all, we need to show them the evidence, and that's why it's so important to get published evidence, hard evidence, to be able to take it to policymakers and say, hey, look, this is hardcore evidence that if you do something about poverty, it reduces suicide. So get your asses moving. Yeah. Absolutely. Yeah.
All right, next was, that table, there are 3 there, and then we have 1 there, and then 1 at the back.
Hi, thanks to the panel. Great panel, great chairing as well, by the way. David McDade, London School of Economics. I just want to make a couple of points, observations as well. One, I think it's really, really, really critical, in my view at least, that when we're thinking about suicide prevention, we are absolutely moving outside of healthcare systems. It's just fundamental, because we really need to think about the social determinants of health, inequalities in health. So the points made about access to or tackling poverty are really, really important. And so just an observation, because I've been involved in work on conditional cash transfer programs and their impacts on mental health in a number of countries. And actually the evidence base is a bit mixed. We weren't looking at suicide, we were looking at depression and other measures we could find. And one of the reasons they're mixed is because the data sets they're not measuring things that are useful from our perspective. So they don't look at anxiety. And anxiety is an incredibly important factor for young people. So there are some issues there, but there's a lot of promise. And I think as well the point about COVID, this is, a lot of people will say that one of the reasons we didn't see the increases in self-harm and suicide during COVID that we might have anticipated were about these substantial welfare programs that were put in place in many countries. So the question, so there's a couple of points. One is a question is, are there more things we can learn about large scale but small amount micro kind of welfare support programs from Southeast Asia, for example? I know in India they have a large program, but as well as in Brazil, but also think about what's feasible and realistic to collect routinely with these programs, so that in the future we can actually try and demonstrate to governments that they make a difference. And then the second very quick point is, again, just to emphasize the importance of peer workers and community workers. There's loads and loads of experience from places like India. I was involved in evaluating depression programs delivered by trained volunteers with a few days training, and they're going out delivering services. And more critically, those programs have been replicated in high-income countries now. So I think there's a lot of learning that can be done from the South. So the question is there more that can be done with community volunteers, with peer support workers and similar in terms of the suicide prevention space as well? Because I think there's a lot we can learn from that.
You make an excellent point. I think I would just like to highlight work from, where was it again? Ethel in Africa, I believe, where they actually train volunteers to actually do low-intensity treatment for depression in HIV, and it's been very successful. So I think absolutely, David, you're right. We have to look at what we have and not always think that we have to do it in a very high-tech kind of way. Low-tech is good tech and very cost-effective too. So I think that's absolutely the space that we have to leverage on, and everybody can learn from it, because if it applies in low and middle-income countries, why not is it not applicable in high-income countries where sometimes resources are also very scarce? So I think absolutely, you've got a great point.
Yeah.
Great session. So I just want to ask about, I think the point Dr. Mishra was making about self-management strategies or family management strategies. You know, I spoke earlier about safety planning, and that really is a self-management strategy, right? You're empowering patients to be able to address their suicide risk using their own, you know, unique sort of approaches. And so has that come up? And I'm sort of like wondering how those, something like safety planning or some sort of self-management has come up in each of your settings.
I think what we have done in Nepal, like we have a program which says like my health, my responsibility. Although this program has been taken up by our other department, that is the Department of Ayurveda and Alternative Medicine. And what we have done that this my health, my responsibility, it has a few checklist type of things. So this has been translated to all the communities and all the local units. So in Nepal, we have like 753 local municipalities, and all the municipalities, the mayors and the chief of the municipalities, they are being trained on this My Health, My Responsibility app. So once my idea is from a treatment point of view or from a Department of Health Services point of view, where we implement the services and where we are responsible for sending the medicines and other things, that most of the things, as was being mentioned, like the anxiety and some mild depressions, if we can propagate a model of self-care through this My Health, My Responsibility, which looks after your nutrition, which looks after your, your exercise and your day-to-day activity. It actually takes those stresses away from your life, which might cause, like a certain level of anxiety. And once you have these, once these stresses are gone off, because we are different personality, we all have different personality traits. So it might decrease the urge or the urge to commit suicide. That is one of my hypotheses, or I feel that way. The other thing would be, because we all understand that there are socioeconomic stresses, and socioeconomic stresses cannot be taken care of through the government, although the government has a responsibility. But then the responsibility towards self-care or the family, or making a family happy, or how to stay happy, I think the point what I'm trying to make is, we all need to propagate this concept. And there may be different ways of doing this in different communities. It may be a religious meditation, it may be anything. But then how do we integrate this in our day-to-day life? The concept is more important. That's what the point I was making. Yeah, thank you.
Yeah. So
One thing I'd like to add on this question, that I think that education institution-centric prevention activities is actually working well in our countries. So I think that will be also work well in other countries. And second thing is that life skill, we do not have enough life skill in our education institutions. And also in this curriculum, so we need to include mental health and suicide prevention in our education curriculum from the primary level. Yeah, that will be important.
thank you. So we have a question. Yeah, please.
Yes, my question goes to Al Harun. You've been able to let us know that suicide is still illegal in Bangladesh, and it has some limitations in terms of your suicide prevention efforts. So are there any efforts by organizations to find a way to decriminalize suicide so it becomes easier for you to do your work? And then I also want to stretch a little bit the comment by Dr. Khan about the use of patent medicine dealers who have not received any formal training in terms of educational training in dispensing drugs, but they are scattered in most of the communities we find in the developing parts of the world. So I'm going to be interested in knowing if any of the panelists have, working with the communities or in the community settings, have been able to work with this important group of professionals, so to speak, in suicide prevention? Thank you.
Yeah, I think the first one was decriminalization reform. Maybe you can take that question, and then maybe Harun can take the second question.
Yeah, thank you. I think that the decriminalization of suicide is actually both political issue and as well as the legal issues. So we are developing one platform. That's a platform for suicide decriminalization in Bangladesh, and we have to manage the government. I mean the Directorate General of Health Services. They are convinced. I mean the bureaucrats are convinced about the decriminalization, but we need to more work on with the politicians. So as well as this is the sensitive issue in like our countries, the religious groups are also there. So we need more advocacy with the government, what we are doing now, and we are hopeful that we can do that. Thank you.
Right.
I'd just like to add what kind of worked in Malaysia that might be applicable in other countries where there's a lot of high stigma and there's a lot of push and advocacy political will. What happened was the religious communities were engaged right from the get-go. And as Sandy has mentioned, if suicide is seen as a sin, how noble it is to actually reduce suicidal behavior. And all religions actually keep to the sanctity of life. So if you go along those lines, you won't go wrong. And the religious community leaders, you know, they would not push back against decriminalizing suicide so much. And you have to get their engagement because faith leaders are very important community leaders in our communities. And if we talk about political will, what we learned from our exercise of democratization was the health minister was very invested in it, but he could do nothing in parliament to actually overturn the criminalization of suicide. What actually was needed to engage the right person, the right politician, which is the Minister for Law Reform. And you actually had to engage, it was actually crucial to engage that particular person to see that decriminalization of suicide actually makes life easy for so many people. You cut down the cost of actually going out to actually catch people and apprehend them and throw them into jails. So much of that budget can actually go into investing in health. So if you can get the right people and the right politicians to see your view, you will win the day.
If it's one thing I can add to that, is when you're speaking, at least in my experience working in Indonesia and in other surrounding countries, is when you sit one-to-one with a lot of these decision-making and policymakers, you can really drill down what is it that they're thinking. And it might not be immediately apparent from necessarily what they say on the news, because that's often curated. And it may not necessarily be apparent from what the media or other influence says about them. So for example, the situation in Indonesia is that suicide isn't criminalized, but self-harm and suicide attempts aren't covered by universal health care. And so that's one of the things that we're advocating, to be able to enable 3% of the global population to actually get care. And so I sat down a couple of days ago, back when I was in Indonesia, with one of the deputy heads of this organization from Universal Healthcare. And what I'd really like to emphasize is the more in our arsenal, the more we can address their concerns. So they ask about economics, if they ask about the morality, if they ask about moral hazard, if they ask about the research, and if they ask about religion, the more that we're able to know, the more we're able to address exactly what they're thinking about. And the reason I bring that up is because the last question that this individual asked me, she said, Sandy, we were brought up from such a young age, because in a predominantly Islamic country, that suicide is something that you just don't do. How can it be that in the largest Muslim country in the world, that there are so many people dying by suicide? That was what was really in her heart. That's what she was thinking about as she was thinking about whether to make these decisions or not. And the way that I addressed that is, I then took the conversation to say, well, that goes to the argument that we cannot consider suicide as moral hazard, because individuals, when they die by suicide, they experience such intense, intolerable suffering that their agency may be impaired. And so that's why we really need to meet them where they are, whether it's somebody who's thinking of ending their life, or even if it's the politician thinking of making that decision or not.
Yeah. Right, so we are getting close to the time. One question there, and then where's the mic? There was a question there, no? Then maybe this one. Yeah.
Over here.
There was someone, but I don't see a hand raised now.
No.
So then here, yeah.
Oh, I'll come back to you.
Here first, please.
Sorry.
Thank you. Look, firstly, wonderful panel, wonderful discussion, great panel chair. Last year, the United Nations General Assembly passed a resolution on mental health and psychosocial support, reflecting some of the work done in the Lancet Commission around sustainable development goals, where it explicitly named mental health and psychosocial support, and reflecting other conversations around the importance of looking more holistically, if you like, or broadly, around the issues that affect people's well-being. I've heard a fair bit of what I would term psychosocial support referred to in your discussions today. You know, talking about the notion of equipping individuals to self-care, looking at the notions of coping, of emotional support during times of great stress, looking for what families and other forms of social support might be available to a person immediately, and how productive or helpful they might be. And certainly looking at the social determinants of a person's well-being and how you might address some of that, anything ranging from practicalities of providing adequate food through to major policy shifts around, you know, financial cash assistance and the like. So my question for the panel is, do you think actually that zero suicide healthcare should be retermed zero suicide healthcare and psychosocial support?
Yes.
Who is going to take that?
The reason is this.
So it has to be one person, because we have one more question and then stop.
Okay, so I'll be very quick. What we learned this morning is absolutely essential to a society and community that has zero suicides. We need healthcare systems that work. But we also need to be able to turn to somebody next to us, tell them that we're having a really bad day, and they know how to listen. So I think absolutely yes.
So one last question then there.
Thank you for this panel. My question was about the WHO Live Life framework that I know is being implemented widely throughout the world. There are a lot of points of overlap and potential synergies with zero suicide. I think each framework could inform the other. So just kind of interested to hear whether or not you all have experienced some of that overlap in your local programming.
So I'll take this one, and another reason is because at 50% capacity, I actually work for the WHO. I'm not here in that capacity, but it's my job to implement Live Life in a lot of different settings. And so I'd actually like to address that and say, I don't think that there's necessarily overlap, but there will be. The reason being is because zero suicide starts off in healthcare, which is absolutely essential to a society that prevents suicides, whereas the Live Life WHO primarily starts in universal interventions, where actually we don't necessarily recommend, and again, I'm not speaking in any capacity at the WHO here, I'm just sharing what's inside the document, that we don't prioritize specific populations, but rather universal interventions. Now, at some point, what's gonna happen, and it's already beginning now, is that zero suicide is moving towards community. The WHO is gonna begin to identify specific populations in area where it needs to develop, and we're gonna meet in the middle. So I think that's where a lot of synergy is gonna happen in the future.
Thank you. And that would be the last response because we are exactly on time. Thank you very much for staying on the time. You get all the credits for that. Really appreciate the sharing of your knowledge. Thank you to Brian, John, and Siddesh, who helped us organize this whole session. I hope you guys enjoyed. Please, there will be slides that you can also look at the Zero Suicide conference website and reach out to anyone if you have any questions. So thank you. Over to you.